ஹலோ, ஸ்ட்ரீம் பண்ணியாச்சுடா. நான் ஸ்ட்ரீம் பண்ணிட்டு இருக்கேன் இங்க உட்காந்து. லிங்க் வெயிட் பண்ணிட்டு இருக்கேன். சரி, ஓகே. நான் ஸ்டார்ட் பண்ணிட்டு இருக்கேன். சரி, சரி, ஒண்ணும் பிரச்சனை இல்ல. சரி, ஓகே, ஓகே. பை.
Sir, good evening.
Good evening, sir. Could you guys hear me?
Yeah.
Yeah, good evening. Good evening, Yashwant.
Yes, sir. Good evening, sir. Welcome, sir. Is Dr. Bala and Dr. Soma joined?
Good evening, sir.
Hi, Vivek.
Good evening, sir.
Good evening, sir. Welcome, sir. Welcome.
Yeah. Mm.
Welcome, sir. So, hope you guys are doing good.
Yeah, I mean, yeah, good.
Great, 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 sir. So I believe we can start the session now. It's already 5.
Yeah, sure.
So
Yeah.
on behalf of Team Professional Helpz and New World Protocol, we'd like to welcome you all for this panel discussion here. So we'll start off with the introductory keynote. So I'd like to call upon Ms. Shruti Rajagopalan to start off the session. Shruti?
Good evening. This is previously known as Zygomycosis, is actually a serious but very rare fungal infection caused by a group of moles known as Mucor. These moles live throughout the environment. Mucormycosis mainly affects people who have health problems or take medicines that lower the body's ability to fight germs and fungal spores from the air. It also can occur on the skin after a cut or a burn or any other type of skin injury. So during this COVID-19 pandemic, this rare fungal infection has escalated quickly out of nowhere, creating a sudden but quite short-term chaos throughout the nation. Many were treated and some suffered the worst. So what led to this? How was this tackled? So today we welcome a group of panelists, expert in the field of ENT, head and neck surgery, to discuss with us about this topic: mucormycosis and endotracheal complications faced during the COVID-19 pandemic. On behalf of myself, Ms. Shruti Rajagopalan, Team Professional Helpz, Team New World Protocol, and the fellow audience, I would like to welcome our respective panelists for the evening: Dr. Major Prasanna Kumar, Dr. Somur Lakshmanan, and Dr. Vivekanandan Balakumar from the Sri Ramachandra Institute of Higher Education and Research to discuss about this topic. With further ado, we shall start the session. So we'll start the question, sir. This is for Dr. Vivekanandan. Sir, could you give us a brief introduction on what is mucormycosis and also what are the risk factors that are associated with it?
Okay. Like you said, you've actually made my points too simple actually. So mucormycosis, as you said, it's a fungal infection. It's an angio-invasive fungal infection that is, spreads through the blood vessels, and it's one of the dreadful fungal infection which we see nowadays, especially after the COVID endemic or pandemic. We are seeing a lot of patients with mucormycosis, and this is normally a fungal infection which spreads through blood, and it can spread through the other parts of the body. Commonly infected are your nose, your sinuses, and your pulmonary region and your skin. So, and like you said, it normally enters, it's a normal fungus. It is present all over the environment. But who are the people who's affected in this? The immunocompromised individuals, that is patients who have been on diabetic medications for a longer time, patients who are suffering from HIV/AIDS, or patients who are immunocompromised in other ways like post-transplant or post-malignancy radiotherapy received patients. All these patients are patients who are termed as immunocompromised. So those kind of patients, when they come in contact with these spores, when they directly inhale it or when wound or any disruption in the skin, it goes through that and can cause mucormycosis in these areas as described.
Thank you so much, sir. This question is for Dr. Major Prasanna Kumar. Sir, what makes mucormycosis a very fatal disease?
Thank you, Dr. Shruti. Thank you, Dr. Ashwant and all your team for this excellent effort of bringing together the panels to discuss and to actually enjoy teaching and learning. Yeah. Coming to your question of what makes Mucor so fatal. Now, the other word which we generally use when we talk about Mucor itself is rhino-orbitocerebral mucormycosis. This is a zygomycosis, meaning to say it's a infection of animals or living things as such, and it's an invasive infection. Now, as you rightly pointed out, Shruti, that this is present in the environment all over the place. It's omnipresent. And as Dr. Vivek had rightly said, you need some immunocompromised state where this gets into the system. And this mucormycosis is angio-invasive mycosis, a fungal infection. So what happens now? The mucor is there everywhere. It gets into your nose and gets out. So when you're breathing in air and breathing out, it comes in and goes out. But sometimes what happens, they stay there for a long time. And then when you have a precipitating factor or an immunocompromised factor, like the uncontrolled diabetes is one of the most common factors which we have found, uncontrolled diabetes and diabetic ketoacidosis. These patients, even a small trauma, can inoculate this mucor into your tissues. Now it becomes invasive. It gets into the blood vessel, as Dr. Vivek had pointed out. It is an angio-invasive mucor. So now it gets into the blood vessels. It needs iron, ferritin, to survive. And once it gets ferritin, it forms a mucor thrombi. This thrombi gets embolized further down. So the first area of affection is either the sphenopalatine artery in the nose. That's the major vessel of the nose and the paranasal sinuses. It is also known as the vessel of epistaxis. Now that gets thrombosed. So the entire area of your nose and the sinuses, one half of your nose and the sinuses, they get thrombosed. They get embolized and thrombosed. Now this starts eating away the iron. It grows. The fungal load grows. Then another thromboemboli is produced. Most often it is in the posterior region of the sphenopalatine artery, the pterygopalatine region. And that's where it gets into the orbit. It gets into the orbit, and from there, by mucor emboli, it can get into the carotid vessels, and then you can have intracranial expansion. It can be direct intracranial spread, or it can be through a mucor thrombi. And that's when it is fatal. If it gets into the brain, you have multiple mucor thrombi spread all over the brain. It starts eating away the brain slowly. And invariably, this is almost fatal, especially in the acute fulminant stage of mucor. Now, as you start your treatment, if you control the diabetes and if you're controlling the fungal infection by antifungals, it becomes into a subacute or a chronic indolent phase, which we will discuss later. But in the acute fulminant stage, it is very fast. I have seen, especially the first encounter of my mucor was when I was working in the army. So this lady just came to me with a small palatal ulcer the day before. I thought, okay, this is going to be an aphthous ulcer, and I started to treat the aphthous ulcer. Next day, the ulcer was huge, and I admitted her. And the third day, the whole palate was perforated. It was gone. It was eaten away. Such was the rapidity of spread of this infection. And we had to go in and do a maxillectomy and remove the entire maxilla and start her on antifungal and manage her. So that is how rapidly it can spread. Within days, it spreads.
Thank you so much, sir. Next question is for Dr. Somu Lakshmanan. Sir, what are the complications caused by mucormycosis which is related to ENT?
Yeah, good evening, man. And again, once again, congrats to the whole team for organizing this. I think every question is almost overlapping between me and Tasna and Dr. Vivek also. So basically, as you know, you have the vital structures like your base of skull, orbit, all around your sinuses. And as previously described by both my colleagues, who have already said that this is a basic infection which spreads through the vessels and naturally it invades your nose and paranasal sinuses. And as you all are aware that your most of these sinuses are all around your orbit. You talk about your sphenoid sinus, you talk about your ethmoids, or you talk about the maxillary sinus. These are all around your orbit. So that's how it easily spreads on causing complications. So basically, it is nothing like just confined only to the ENT part, but the neighboring structures like your orbit as well as your base of skull. So whenever you have a severe infection in and around your sinuses, it need not be a mucor also. It can be a simple acute infection also. You can have a breach of this wall of your orbit. It's called your lamina papricia, as the name is called. It's a papery bone, so it can spread on to the orbit. So if you take the sinuses, so if the infection is all around your ethmoids and your orbit, I mean your maxillary sinus, it can easily invade and causing complications of your eye. As it proceeds above and goes above and look into the frontal sinuses, then it is in close proximity with your base of skull. So you can have any kind of a complication. It can be either a breach or an abscess or whatever getting into the skull base and your brain matter as well. Same way when it goes inside your sphenoid sinuses, as you also know, this is again close in relation to your major vessels, nerves, as well as the skull base also. You have your optic nerve, you have your carotids, and you have your base of skull again here. So any infection in and around your sinuses can reach anywhere. So it's just not confined only to the sinuses. And as it's complications of sinuses, probably you will have a facial swelling, or you can have a prolonged discharge, or you can have a nasal swelling or whatever. But as it spreads on and destroying the boundaries, either by a direct spread or to a vascular spread, you can have a lot of complications. Particularly what we see commonly, like Dr. Prasanna said, what we see commonly is when it involves laterally, it can affect your vision. You can have your diplopia, causing an orbital complication. As it goes down, you can have a palatal perforation or palatal swelling. And postally, when it involves your pterygoids or pterygopalatine fossa, then you can have a kind of a pain around, and you can have a restricted mouth opening. And same way, when it involves your sphenoid or frontal, you are obviously you're going to have an involvement of your skull base. So, basically, it can affect all the systems. It's not particularly ENT. ENT, when we are combining only when you're talking about the nose and paranasal sinuses. But this mucor can affect anything, right from your lungs to gastrointestinal or cutaneous or renal also. But when you comparatively take about your nose and paranasal, it's much more easily to spread on to the neighboring structures, particularly to your orbit. Most of the time, you can see people coming inside with a kind of a unilateral swelling or a proptosis. And that is where most of the people have been referred to ENT. They may not be having much of a nasal symptom, but when they come with a kind of a visual disturbance or a proptosis or something, then probably looking to the eye, they feel maybe some kind of a fungal infection. That is where these people are referred to ENT. And naturally, in a severe cases, they can go in for a kind of an abscess or a kind of an osteomyelitis and involving the skull base also. So basically you have to know about the anatomy of the nose and paranasal sinuses. So when you know the anatomy of the nose and paranasal sinuses, then easily you can correlate with that, or it can keep spreading on. Okay, thank you.
Thank you so much, sir. The next question is for Major Prasanna Kumar, sir. So what is the relationship between mucormycosis and COVID, and what makes it of a big concern to the physician and the affected individual?
Thank you, Shruti. It's a very good question at this point of juncture, because still we are dealing with many mucors post-COVID patient, and it's become a real big epidemic as such. Mucor in itself is an epidemic in this post-COVID era, especially when the second wave had come. Now, we had already diagnosed and managed many cases of mucor in the first wave, but it was not of that epidemic proportions. Now, to give you an example of what happened in COVID, if I can just go through my experience as an ENT surgeon, I had treated around 39 cases of mucormycosis in 5 years. This was recently published as late as last April. This was the article published when we were analyzing the causes of mucormycosis and which type of people it was susceptible to occur. And we found out that diabetes and diabetic ketoacidosis was a predominant cause for mucormycosis. And in the 5 years, I had treated around 39 cases. Now, suddenly, from last year to now, I think we have created, in Ramchandra, at least we have treated more than 100 cases of mucor. That could actually show you how much epidemic proportion this Mucor actually has gone up in the COVID patients. It's just increased so dramatically. Now, why is it happening in this COVID patients? Is it something to do with the COVID virus itself? Is it something to do with the risk factors, the hospitalization, treatment, the steroids? That's a big debate. And I am one of the members of the ICMR team who are actually investigating the risk factors of associated to in patients with COVID who are developing mucormycosis. That's a study which has been going on, and probably by another 2 months we should be having. This is a pan-India study, and so we will be collecting data from across India, and we might be getting the results, or we might be getting an answer another 2-3 months when they compile the study. Now, when they are doing so, let me put it in perspective. What actually happens here? There are many multifactorial things which is happening in the COVID patients. One, COVID as such increases the sugar level. So many of us have noticed, those who have suffered from COVID, including me, my sugars are also had shot up for the first time in my life, and I had actually contacted COVID. Similarly, it happens to every individual. All the sugars, the endocrine metabolism is deranged, and becomes quite high. Now, second thing which happens in COVID is your ferritin level. The free ferritin level in COVID patients is high, and that is why we also estimate the ferritin level in COVID patients. Now, free ferritin level, dysregulation of your endocrinology system, that is especially related to your sugar control mechanisms, diabetes, then dysregulation of the immune system. You know that people suffer from immune deficiency in COVID. All this, in addition to this, then you have oxygen. In the second wave, especially, there was a lot of shortage of oxygen, and probably there was industrial oxygen or contaminated oxygen that was supplied, along with the demand for more tubes, for aerating tubes. So there were many contaminated aerating tubes which were there. The use of steroids, large doses of steroids, actually, they also increase the amount of sugars, that is uncontrolled diabetes. So all these factors could have played a role in the increase in number of COVID patients. So hope I have answered the thing which is required, the risk factors, why it happens in COVID patient, especially during the second phase. Now, there is another thing which the research has shown, that in COVID patient, there is upregulation of the endothelial glucose regulating protein, 72. Now, that's more common in your nasal cavity. And since this is upregulated, it easily takes up Mucor. Mucor takes up these upregulated receptors to actually attack them and get ferritin for it to survive. So probably that is one of the reasons.
Thank you so much, sir. The next question is for Dr. Vivekanandan. Sir, what is the early diagnostic indicator of mucormycosis, followed in ENT?
Okay. Not all patients who have got COVID that we screen for, but we should be doing it. That's what we started right now in our department. But patients who are immunocompromised, who have some symptoms, so the early symptoms that we are looking forward, or we are educating our patients, is to look for bleeding from the nose, crusting of the nose, or crusting from inside the nostrils. There may be either blackish crusts or crust over the skin, over the palate, change or loss of taste and smell, and also swelling over the cheek, numbness over the cheek. These are the earlier symptoms that we were thinking about or we are looking for. And the symptoms that we are also educating the patients are to check for.
Carry on, Vivek. Carry on.
Sorry, okay. To check for eye symptoms. Mainly these symptoms when they have blurring of vision, loss of vision, or if they have a proptosis, that is, displacement of the eyeball, either laterally or forward. So all these are in favor of telling us that we are dealing with an invasive acute infection of the nose and sinuses. So once the patients come to us, we have also seen patients from day 1 to day 5, they deteriorate very quickly. So a simple nasal or a sinus disease, mucormycosis, goes in for a rhino-orbital cerebral mucormycosis. So the first thing which we always tell the patients to look for is bleeding, nasal block, nasal discharge, stuffiness of the nose, unilateral lipids, and unilateral facial swelling, watering of eyes, discharging from the eyes, displacement of the eyeballs, the visual loss or blurring of vision, change in taste, or crusting of the palate in the nasal cavity and in the oral cavity. These are the signs that we are looking for and the symptoms we educate the patients. But it's always better that, it's a good thing for the public to also understand that Mucor is on the rise, and especially after COVID part 2 or the wave 2. So patients who are newly diagnosed, young people we see been newly diagnosed with diabetes, they also fall into this category of contacting mucormycosis as their sugar levels are increased, like us described by Dr. Prasanna Kumar. So these are the things that we've been looking forward for and to look for. And if there's any symptoms that we see, it has to be immediately investigated in the way that we do with endoscopies and scans.
Thank you so much.
Just can I put in some
Yes, sir.
pictures so that you people can understand what Vivek
Sure,
actually tried to say?
Sure,
And
sir.
just share my slide for you. I think you will be able to actually appreciate things better. Yeah. So what Dr. Somo was trying to say, Mucor is angioinvasive and it needs metals to survive, especially ferritin expands by mucothrombi. And this is what the picture is. You have the spinopalatal artery. If the spinopalatal artery is actually mucor thrombosis occurs, then this entire area of your sinuses, paranasal sinuses, gets affected, including the orbit. Now, if the infection is in the ethmoidal region, then your orbital artery, the anterior ethmoids and the posterior ethmoids with the frontal artery, this gets embolized, and it affects this part of the region of the paranasal sinuses. So when you do a 3D reconstruction in a patient with Mucor, now this is a advanced stage of presentation, where you can see how much of the bone is actually necrosed. The entire maxillary arch,
Sir,
all these.
Sir, I think you are.
Slides are not moving, sir.
Yes, it's okay.
Oh, okay.
Your slides
Sorry.
are there. No problem, sir.
This is
Slides
okay?
are
Are you seeing the slide now?
Yes, sir.
yes, sir.
Do you see?
Yes, sir. Yes, sir.
Yeah, so this is a patient of Mucor with facial swelling, ptosis, and ophthalmoplegia. This is the most common symptom. Whenever you see ptosis, ophthalmoplegia, this is the commonest symptom. Next, you can see patients with palatal ulcers. That's another patient. If you have loose tooth, palatal ulcers, palatal necrosis, that's another patient. That's another symptom. This is what I meant by actually ophthalmoplegia and ptosis. This is a characteristic feature of a patient with a rhino-orbital mucor, ptosis with ophthalmoplegia, where the eyeball is immobile or there is difficulty in moving the eye. Yeah, so these are some of the symptoms or photos which I have actually shown to you.
Thank you so much, sir. We'll move on with the questions, sir. This question is for Dr. Somu, sir. Sir, what do you think are the precautions that one have to take for, so that they don't get mucormycosis?
Yeah, I think basically, as initially talked about, this is a fungus which is growing everywhere. It's throughout your environment. So if you start thinking about precautions, what we are doing, which we have not been doing it probably long back, is that maybe probably we have to start thinking into a kind of maybe a poor hygiene or maybe a frequent hand wash, face masks and all these things, whatever we are trying to do right now. maybe you have to start doing it as a routine one. And when you're thinking about as it is freely available in the soil and all these things. So particularly people who are in a kind of an immunocompromised state. So it's better to avoid these kind of a soil, vegetables, or kind of a unhealthy area to be avoided, including dust and kind of a what's that, kind of a wet environment. So this is the basic things which we are trying to see for trying to prevent kind of a mucormycosis. But when it comes beyond that, you are trying to think about something more than that. The two people who have been on receiving long-term steroids, or who are there in ICUs, or uncontrolled sugar levels. Even though we see some people without an diabetic involvement, but most of these people have an kind of an uncontrolled sugar levels. So I think anybody with this present scenario who's got a kind of an uncontrolled sugar levels have to be checking that to the endocrinologist and checking to have an adequate control of these sugars. And other than that, we are talking about probably the delta strain, which is still again unproved, or like what Dr. Prasna said is about the industrial oxygen, which is all rampant at this time of the phase, where was there any kind of sterile water which was used, or is it kind of the metals and all these things, industrial oxygen, the cylinders, all these things are also we kept in mind kind of prevention. Ultimately, a good proper hygiene and probably controlling your sugar levels are the most important things to think about having an adequate control of your fungal infection.
Thank you so much, sir. The next question is for Dr. Vivekanandan, sir. So, what's the importance and burden to a common person that they must know about mucormycosis?
Okay. So, mucormycosis as such is, I would say, it's a very costly disease that we've been seeing. Everybody is infected. It doesn't infect only the lower cadre people, or it is not the upper cadre people. I've seen patients from the lowermost cadre to the uppermost cadre. Even the rich gets infected with this. So what happens is, number one is it's very costly. The treatment for it is very costly. The hospitalization, again, it takes a long time. Everybody has to understand it's a very, very slowly treatable disease. It's not done in a single stage. So the patient and the attenders have both to be properly counseled regarding the disease and the need for recurrent surgeries and recurrent investigations. And also, what we should also know about is it's not a single surgeon's disease. It's a combination of every doctor coming together. It's like a group work. So you should obviously include your endocrinologist, your physician friend, your neurologist, your neurosurgeon, and your ophthalmologist, along with your speech pathologist and other supportive, medical helps that you need for these patients. So number one, the first they should know is it's monetarily, it's high. The main reason, even though the surgery is done for free, everything is free, the medicine that has been used to treat mucormycosis, one ampule of amphotericin costs thousands and thousands of rupees, and each of them receive nearly 20 to 30 ampules of amphotericin, which itself will come up to about 1.5 to 2 lakhs in this current scenario. And we cannot, there's no other alternative treatment for mucormycosis, and this has to be done. The patients and attenders have to be explained. Number two, they also have loss of function, such as loss of smell. In few patients, the loss of vision has to be clearly explained so that we do not get into a puddle later. So everybody knows that this is something really equivalent to a cancer treatment, where there will be loss of function, there will be loss of even eyes. Sometimes we have even removed the eyes for some patients. Some patients have gone in for stroke due to involvement of cerebral area in mucormycosis. So it's a long process. The patient has to be taken care periodically, and the recurrent infections is common, and the recurrent investigation has to be done. This is what the patient and attenders have to know. And this is every doctor's, everybody in the doctor panel should understand that this is what's happening. And this has to be told to the patient and attenders so that they are ready, both monetarily, financially, physically, and mentally, they're ready to support the patient and the attenders.
Thank you so much, sir. The next question is for Dr. Major Prasanna Kumar, sir. Sir, what is the management protocol that we do for mucormycosis in the ENT part of it?
Thank you. Thank you, Shruti, for being more specific from the ENT part of view. Now, as far as mucor management of mucormycosis goes, as rightly told by Dr. Vivek, it is not a individual treatment. It's just not ENT who's actually going to manage mucormycosis. Am I audible actually? Is it clear to you?
Yes,
Yeah,
sir.
yes, clear, sir.
So it's basically a team management. You just can't say it is done only by the ENT specialist, done only by the medical specialist, done only by the endocrinologist. Basically, it is an entire team effort and how a coordinated team actually works. Now, as far as the management of mucor goes, the first thing is high index of suspicion. A high index of suspicion is one when you pick up this disease at an earlier point. Initially, when we used to diagnose mucor, we used to talk about high index of suspicion when the patient actually comes with a necrotic tissue in the nose, or when the patient has an orbital complication or a ulcer or a palatal ulcer or necrosis, as I had put it in the picture. Now, these were the signs and symptoms which were earlier used to diagnose a case of mucor. The patient has already developed orbital complication, a dental complication, or he already has a necrosis in the nasal cavity. Now, that is already a progressed mucor, and it is fastly progressing. It's a fulminant mucor, and it's going to get into the orbit and into the cerebrum. Now, in the COVID patients, in the post-COVID era, as we started to recognize more and more mucor, any symptoms of mucor, sinusitis, we presumed that it is mucor, and we used to go with the investigation, radiological investigation, especially the MRI. Previously, we used to use the CT to look at the bone destruction. But now what we did, the entire concept changed. A patient with symptoms of sinusitis with paresthesia in one side of the face, we used to go and do a MRI of the nose and the paranasal sinuses with contrast. Now, if this MRI showed a sinus, hyperintense lesions in the sinuses and the surrounding paranasal sinuses, if the inflammation is extending beyond the paranasal sinuses, we treated these patients as mucor, and most of them turned out to be invasive fungal infection and mucor. So we could get to them earlier. And early nasal debridement, we used to do an endoscopic nasal debridement. Now what happens in endonasal debridement is, one, you get to diagnose the disease, that is with a simple procedure like the KOH mount. That is microbiology. We have a potassium hydroxide 10% KOH mount. You can differentiate a septate hyphae from aseptate hyphae. If it is a broad aseptate hyphae, it is a mucor, and you start your medical treatment immediately. If it is septate hyphae, then you are looking at a invasive aspergillosis. Both can occur in a COVID patient. Now, if it is mucor, then it is histopathologically proven that it is invasive mucor or microbiologically proven, then you need to start your treatment immediately. The treatment consists of controlling diabetes, controlling diabetic ketoacidosis, correcting the electrolyte imbalance of the patient, and immediately starting on injection amphotericin. Now, amphotericin B is the drug of choice for treatment of mucor, invasive fungal infection. Now, if the patient, now the problem with amphotericin B, as Dr. Vivek had pointed out, is the cost. There are three types of amphotericin B which is available: the conventional amphotericin B, the colloid form of amphotericin B, and the liposomal form. Now, the liposomal form of amphotericin B is available as a 50 milligram of amphotericin, which will cost 12,000 rupees. Right? Now, if you have to give a dosage of around 150 milligrams of amphotericin, just imagine the cost. The cost is around 35 to 45,000 for the injection itself, amphotericin, liposomal amphotericin itself. Now, during the COVID, when this was an epidemic, we had a problem of amphotericin B, liposomal amphotericin B. So we had to switch over to conventional amphotericin B. Now, conventional amphotericin is cheaper. You get it for 400, 500 rupees for 50 milligram vial. Now, you can manage with the conventional amphotericin B, but yes, you should remember that there is a toxicity with conventional amphotericin B, more toxicity. What are they? A patient generally has signs of fever, shivering, chills, which is more common in conventional amphotericin. Sometimes a patient has a deranged renal function and also a deranged electrolyte balance, that is a potassium hypokalemia. So hypokalemia is one factor which you have to keep on monitoring when you're giving amphotericin. You have to monitor creatinine, that is the renal function when you're giving ampo. And also you need to look at this fever, chills pattern and manage. Now you need to involve your physician colleague, the medical colleague, in helping you manage this. As a ENT surgeon, I would not go on treating because already you're burdened to operate on the patient. Now they come in for the management, the medical people. So this becomes a comprehensive management where the ENT surgeon operates from inside, reduces the fungal load. Now, medicine gives amphotericin, which attacks the fungus from the outside to control it and limit the spread of fungus. Now, this goes on. Now, some people do not tolerate amphotericin B. So you have other antifungals, posaconazole, which has come into market. All these help in management of fungus. So basically, surgically, we reduce the load of fungus, and medically, we try to kill the fungus from outside. So a combined team management is the protocol of the day.
Thank you so much, sir. The next question goes to Dr. Somu, sir. Sir, what is the meaning of AMD mucormycosis, and what is the treatment that is followed in such a case?
No, I think whatever you're asking is probably the liposomal amphotericin. That's what you're trying to mean. Basically, what I think Prasanna has almost given 70% of the answer. So generally, for anybody who suspect for a fungus, we have to be aggressive, medically as well as surgically. The only debate, like Dr. Vivek said, is the affordability here. If you're affordable, then well and good, you don't have issues. So if you're not affordable, then we have to start thinking about what are the basic amphotericin which we can give. So that is what I think the liposomal and all these things are all come recently only. So we take about a few years back when most of these renal transplant patients who were admitted and they were all kind of a suspicion of a fungus. These people were given a kind of conventional amphotericin. That is which has been used regularly in you take MMC and all these places. But with the advance and with the toxicity and all these things, this liposomal amphotericin B has come. So you have three things. One is like conventional, then you have the lipid or the emulsion form, and the other one is the liposomal. And as these three, the latest one naturally, anything which is latest is going to be better, right? So the amphotericin B, which is having a less toxicity, whereas if you take the conventional one, they are more toxic, and you have to monitor them every time with kind of renal function, whether they are altering or you have to go for your electric imbalance. So they have to be on quite a strict monitoring for all these patients, because most of these patients are quite sick also. So already there might be electrolytes dearranged with kind of an uncontrolled sugars. So all these things have an impact on the medication. So yes, the drug of choice is going to be liposomal B amphotericin, no doubt about it. But still, in case you can't afford, then you can go for the conventional also with a proper kind of a nephrologist as well as a physician or maybe an infectious disease person. In case sometimes what we see here also, if the fungal load is quite okay and we are happy after a complete debridement and the physician asks us, sir, we still continue this liposomal amphotericin B. So based on how symptomatically patient is improving, and you do a nasal endoscopy, you do probably repeat CT scans, and all these things also helps you to tell whether the load of infection is more or quite less. If you are quite satisfied with the clearance, patient is also responding well, sugars are controlled, and his kind of a fungal infection is definitely less, you can straight away switch over into a kind of an new ones like your lesser costly ones like your posaconazole or isaconazole. So, but to start with, there's no compromise on the surgical as well as it is going to be liposomal B. Affordability, yes, it matters. In case you can't, then probably you can also think about conventional, but naturally you have to monitor them in close watch because if you're going to give in conventional, the toxicity is more, but you don't have an option. If the clearance is good, as I said, the clearance is good and patient is symptomatically better and a repeat MRA or a CT shows no much of a residual disease, you don't have to have a definite regime that this has to be given for 6 weeks or 8 weeks. If it is going to be a little aggressive infection, like it is spread beyond the nose and paranasal sinuses, it is involving your orbit or is involving your skull base, or you have an abscess also which is caused by the fungal infection, maybe you have to have a long-term AMP-B liposomal amphotericin to be given. So ultimately, it varies from person to person, the disease per se, as well as the tolerability of the medication. Some people don't tolerate even for any kind of amphotericin B also. So in these cases, probably you have to start switching over to posaconazole or isaconazole, and then to be on a regular follow-up and to watch it, and probably again restart if the disease is spreading on. So there's no definite thing that it has to be given only this, but you have to change the medications. Like our team also has already said, this is a particular team effort, which primarily we as an ED people, we will be having a close watch, looking to the nose and paranasal sinuses to see how much this is healed. But yes, the primary people are the physician and the nephrologist who is going to guide us whether is it going beyond the toxic level or whether anything has to be modified in the medication. The other one is the conventional one, which we talk about, AMP-B, is amphotericin deoxylate. That's what we are talking about. But nowadays, we always prefer to have amphotericin B because that is the causing the lowest or the toxic features are less.
Thank you so much, sir. The next question is for Dr. Vivekanandan, sir. Sir, what is the exact role of the ENT specialist in the case of a mucormycosis?
Okay, if we have listened from the first, what I said, sir, and Somu sir said, everything put together is the anti-surgeon's role. But yes, I'll put it in a very, very concise way. We are like the bridges, okay? We are like the bridge between the disease and the physicians. So we make the physician available to the disease. That's all. So in other words, we diagnose. We help in the diagnosis by doing a diagnostic nasal endoscopy. And during the endoscopy itself, we will take some fungal smears or culture for fungal smears, which will help us in identifying whether it's a broad aseptate fungi. That is what is mucormycosis, and differentiated from other group of fungus. And where are the destruction process? Where is it happening? Is it the maxilla, is it the modal sinus, whether it's not the orbit, or where all is the destruction process happening? So the extent of the disease, and then planning. So what we do is not just a sinus surgery or a functional endoscopic sinus surgery like we say, like Professor Kumar sir described. We do an debridement. It's like an infection which has caused necrosis of the tissues. So we have to debride those tissues. Leaving those tissues back is going to cause more fungal infection in that area, or it's going to be a place for more fungus to eat upon and grow upon. So we have to debride all these tissues, which also includes debriding of your maxillary bone, debriding of your nasal tissues, turbinates, and sometimes the orbit as well. And this is the only part of an ENT surgeon where we help in diagnosis and we help in reduction of the fungal load for the patient before we hand over the patient to the respective department like neurosurgery or a dentist, or it has to go to the physician for amphotericin B injections. But the ENT surgeon's role is not over with that. We have to eventually see them periodically every week or every other week to see how far the disease progressed, or it is regressing, or it stopped. So once it's stopped and it's not further growing, we know that our job is done, and we periodically check them once in a month or once in 3 months to see whether they have new focus of this infection anywhere else in the nose and paranasal sinuses. And if it is there, we have to again rewrite all these tissues. That's our role as an ENT surgeon. We just act as a bridge between the disease and these tissues.
Thank you so much, sir. The next question is for Major Prasanna Kumar, sir. Sir, what is your view on post-infection recovery in the case of a mucormycosis?
Thanks, Shruti. Can I just share my slide to answer this question? I thought it will be more apt for the students to understand what exactly all this is about. Now, as recent of 2020, we did not have a guidelines on use of amphotericin or what type of antifungals we are going to use. And 2019, the European Confederation actually came out with the guidelines, and this has been published in the Lancet, the journal Lancet. And I would request all of you to actually just at least download this article and keep it as a guidelines if at all you want to learn what you're going to do with the management protocols. Now, as far as the this thing is concerned, the amphotericin is concerned, those who are resistant to amphotericin, especially when they have a pre-existing renal disease, then the drug of choice which is recommended by this council is isavuconazole or posaconazole. Now in India, we use posaconazole for a longer period of time. Now, as far as the surgery is concerned, surgery can be just a little endoscopic debridement of the nose shown here. Just go through the nose and remove all the dead tissue. Or it can be, what I have started to practice is the transoral surgeries for most of the mucor. So I go via the oral cavity and do a transoral maxillectomy so that it does not leave any facial disfigurement. So even for extensive mucus reaching up to the frontal, ethmoids, sphenoids, and also the lateral zygoma, nowadays I've been doing a transoral maxillectomy. Previously, we used to do a Weber-Fugenson's incision. We used to cut open and then remove. This used to give us a little bit of scar and all those things. But now most of our cases are transoral. How extensive the disease is. Now, I'll just show you one of the COVID mucus presenting with ophthalmoplegia and ptosis. So the second day of diagnosis, this patient came, we took a KO smear positive for aseptic typhoid. Second day, we went in and did a debridement. Sorry, this was in the same day, the same night I had to come and do the endoscopic debridement for this patient. So this is how here, that is not a black scar. You see a soggy tissue. This is how early mucor looks, pus and soggy. It's not dead tissue. Now you'd go and do orbital decompression. That is, this is your lamina paprica removed, and you see the orbital fat is also necrose. It's a dead orbital fat tissue. Usually it is lively yellow. And you decompress the orbit, remove as much as orbital dead tissue as possible, and this is how the recovery of the patient occurred in the other 3 days. You can see she started ptosis improved, ophthalmoplegia improved, and nearly we had to struggle with this patient for 6 more months till she finally, we declared a cure or stopped her medication. That's one. And this is another patient who had a septal in the frontal region. She had a mucor. The disease was extensive. So we went transoral, and with the help of neurosurgeon, a cranio flap was taken and we debrided. Now care was taken as much as possible to preserve the outer skin. So debridement, neurosurgery helped, transoral debridement by ENT surgeon, medical management by the physicians. Now, this is the end result. The patient is happy. We are able to, at least maintain the external figure of the patient. Now, this was one of the persons who presented only with a frontal mucor. Now, we had to remove the entire frontal bone. You see the dura is open, the brain is open. Then we need to reconstruct with the metal. This man also recovered. One of the biggest cases which I had seen, the severest cases of Mucor was this guy, 26-year-old guy, recently married. He had frontal mucor, a maxillary, ethmoid, sphenoid, and intracranial mucoid. He had this was the extent of mucormycosis destruction which had occurred. It had destroyed one of the eyes. One of the internal carotids were stenosed and narrow. And so we had to do a massive debridement. And then we had to go, after we had treated him, he was cured, he was having a healthy mucosa, we had to give him prosthetic rehabilitation. And after 6 months of struggle, this patient is doing good with not much of a disfigurement. So when do you treat, when do you think that you stop the treatment? Once the pain and the ophthalmoplegia, all this starts improving, we stop amphotericin, we switch over to posaconazole for maintenance therapy for around 3 months, follow up these patients regularly for another 3 months. So till 6 months, we treat these patients, and after 6 months, if there is no symptoms, there is no tissue evidence of mucor, when you take biopsy of granulation tissue or the bone, that's the end point of treating mucormycosis patient. Is that okay, Shruti? Is it what you wanted?
Yes, sir. Yes, sir.
Thank you.
Thank you so much, sir. The next question goes to Dr. Somu Lakshmanan, sir. Sir, what is the prophylaxis that one can do for mucormycosis?
You mean how do you prevent it? That's what you're trying to say.
Prevention and prophylaxis, yeah. Same.
Yeah. See, the treatment part, as I said, there's nothing like you're just going to stop with the surgical or you're going to stop with the medical treatment. That's a team effort that includes everyone, right from the neuro to ENT to infection control or to a general physician or to an ophthalmologist. That is what, so there's nothing like you can stop. It comes and probably we have to start doing it aggressively. Basically, how do you prevent this fungal infection? That's what we are going to think about it. So as you have a high suspicion, so you have people who are in control in the case of who are long-term on immunosuppressants or long-term steroids and whose sugars are all these people. I think with the history of post-COVID, you have to be very, very, very cautious and you have to be strict in looking into a nearby physician and to see for if you have any kinds of problems like you have a nasal stuffiness or kind of a change in vision or something, immediately you have to go and access your specialist there nearby to check whether is there any kind of suspicion of a fungus. So anybody who's having a high suspicion, yes, they have to be checked into going thing, particularly post-COVID, and we are seeing most of the patients are COVID. I'm not saying only COVID should be, but when you have a non-COVID also with all these things and you have a findings, then probably you have to think. Yeah, other than that, if you are able to access a person nearby, then you definitely, as an ENT, we would suggest you to go in for a nasal endoscopy to see for any kind of a suspicion, and probably think about getting a smear done. And to see for any kind of, that's a basic investigation, a nasal endoscopy and a smear done. Or else, in case you're not able to approach an ENT at that moment or something, at least a basic investigation of a CT or an MRI when you have a high suspicion. And once you have all these things, yes, you have to start aggressively going in for an thing. An early stage, you just go in and try to clear as much as possible. Even if there's a small suspicion, you just can't wait and watch because it's spreads so rapidly. Like I think Dr. Prasanna told initially itself, he just had to see a patient within a week. The spread of infection was so rapid. So, and I think early diagnosis is the key for this prevention of fungal infection. So you have suspicion, you have a strong suspicion, often diuretics or steroids or immunosuppressants, and then who has got some kind of a nasal stuffiness or a nasal discharge or kind of particularly most of the people come to us with a kind of a visual disturbance or a ptosis or with a proptosis. Any of these things can happen. So when you have all these things, immediately you have to definitely check with the nearest ophthalmologist or an ENT and get the basic investigation done. That's how you try to prevent fungal infection. Either go in for surgically if it is going to be a minimal area, then you just go clear it off, and then you don't have to go in for a high level of amphotericin or something. Just probably a week of amphotericin, that should be okay. Or if it is not so much, it is just going to be a kind of a fungal suspicion. It may not be kind of a mucor. At least an oral antibiotics, oral anti-inflammatory, antifungals will be helping you in getting the prevention of this fungal infection. So, the basic, what we are trying to say, I think what the whole team of everyone is trying to say is to having a sugar control, to monitor your steroids and to monitor your immunosuppressants. Definitely, you have to have your blood investigation done, as well as to have your physician or an ENT or an ophthalmologist checked in case you have the particular system affected.
Yeah, I do agree with Dr. Somu on all this. It's important, vital for everybody to get their sugars under control. And that's the only prophylaxis probably I can think of. This question of prophylaxis for mucor came because of the controversial media topic where amphotericin was used and antifungals were used in COVID patients as a prophylactic measures to prevent mucormycosis. We don't agree with that. At least in Ramchandra practice, me and Dr. Somu, Dr. Vivek, we don't advocate the prophylactic use of antifungals. That leads to more problem. And when you use amphotericin is when you have a diagnostic evidence that it is mucor. Right? So there is no prophylactic drug. Prophylactic care is preventive care, as advised by Dr. Somu, is very, very, very important.
Thank you, sirs. The next question is open to all of the panelists. Sir, were there any endotracheal complications that were faced during the pandemic? And if so, as an ENT specialist, how did you tackle it? And were there any unique case that you guys faced during the pandemic relating to mucormycosis? And would you like to share with us?
I think Dr. Prasanna has already shown kind of two interesting videos of how he had managed. So I think we are all part of the same team. So I agree with what Prasanna showed. So all these are not straightforward. These are all some interesting cases. I think if you start into the amount of mucor fungus as a team of ENT people we have done here in Ramchandra, we have done something phenomenal. And if you start sharing, then probably it is going to take another 1 hour. So I think he has already given a glimpse of two excellent cases. I think that should be an way opener for you guys. And related to the endotracheal and all these things, and that's a kind of entirely scenario, not directly related to mucor, it may be related to COVID disease as well. So that is a kind, I think Dr. Prasanna wants to tell something about it.
So thank you, Dr. Somu, for this thing. Yeah, the first thing which happened was way back in April last year, when I received desperate calls from Apollo asking me to do a tracheostomy, where no ENT surgeons was actually willing to go and do a tracheostomy. None of the ENT specialists ventured to do a track. So this was a 28-year-old young orthopedician. I won't take his name. He had contacted COVID, and his lungs were totally damaged. So that the entire lung was all of cavitary pneumatic lesions there. And the intensivists were desperate. The doctors were desperate to save him. So I desperately received this call, and I went, and without hesitation, we did a tracheostomy for him. And after tracheostomy, after 2 weeks, this doctor walked out of the hospital walking. We cannulated him and we walked out. And that's the time when we actually started doing tracheostomy for COVID patients. Many tracheostomies we did, and we also sent this for approval by, to journal article. Dr. Vivek very well knows we were doing so much of tracheostomies during that time. We sent it for a journal article, and the journal wanted a clearance from the WHO. WHO snubbed it down, saying you don't do tracheostomies for a COVID patient. This was early in the first wave I'm talking about. And we countered it, saying it is ethically not correct on the parts of a doctor refusing a tracheostomy just because he or his colleagues might get infected because of COVID. Now you take your safety protocols and we do the tracheostomy. But still WHO turned it down. But now in the second wave, WHO comes back and says tracheostomy is much useful when done early in patients who are intubated. Now that's a dramatic turn. I sometimes wonder what type of protocol these leaders actually make. Another example of this endotracheal intubation was I was doing one tracheostomy for a COVID patient in a ward, and suddenly I had a desperate call from another ward where this patient had extubated twice. He was a COVID patient. He had extubated himself twice. That the endotracheal tube had come out twice, and the third time they couldn't intubate it. So at that moment, Dr. Vivek was besides me, and I told him, Vivek, rush, go to a track there. And he started off the track there. Next, we put the patient in the next bed, and he started off the track there. And we could save that patient. And I still remember the patient when he walked out, he folded his hands and just gave us a smile. That was something which we had actually achieved. And since then, me and Dr. Vivek and the entire fraternity, Ramchandra fraternity as such, ENT fraternity, have never hesitated to stop doing tracheostomies, if at all it helped. Whether we were at high risk aerosol projection, compromise or whatever it is, we thought, these patients deserve to survive, and probably we went ahead without even bothering whether it will be affecting us. I think Somu wants to give something.
No. If it's not, sorry for your interruption. I just got some call to go. Is it okay? Can I leave? With your permission?
Sure, sir. Please go ahead.
You just keep continuing. Thank you.
Thank you, Dr. Somu. So from then on, we had a lot of interesting things of how tracheostomy, doing a tracheostomy, the complications which occurred during tracheostomy, they were unique. They were unique learning points. We had a separate protocol for doing tracheostomy. We made our own protocols. The complications which occurred were totally unique. How we managed the complications. Because after tracheostomy, these post-COVID patients were on heparin. We couldn't stop coagulants. So probably some of our patients had post-tracheostomy bleeding through the tracheostomy site. And we had to manage that also. Many people had spontaneous pneumothorax. We had to ask the pulmonologist to come in to put in an ICD also. So there were a lot of problems which happened during this time, and we almost successfully managed many patients, and many patients survived, got decannulated, and went home. Thanks to the team.
To add to what Prasna was saying, first few tracheostomies, what me and sir were doing, we were nearly doing blind tracheostomies, because we didn't know how to do it, because we don't want us to get exposed. So we were wearing some shields, which that once you go inside the ward, you start sweating and everything gets fogged. Especially both of us, we used to wear spectacles, and we can't see without spectacles, right? So it gets fogged, and by the time we reach trachea, we don't know where we are. So blindly palpating the trachea, we used to make an incision, putting the trachea. It was a difficult experience, but different. And we progressed to a place where we got our PAPR suit, which is It gives a negative pressure inside your face, I mean inside your head area, so that you don't sweat and you don't have that fogging. So the vision was good. Also, to add up to what Sir said, another thing what we were seeing apart from bleeding from the tracheostomy sides, we also saw a lot of patients, especially with COVID, the tissue mucosa or the mucosa of the tracheal region was completely necrosed in few patients. Could be because of the COVID infection as such, or it could be because of multiple intubation that area is totally necrosed. And we saw a few cases, like about 2-3 cases, we saw the trachea was totally necrosed, the cartilage was necrosed, and the mucosa was so unhealthy. And those patients were really difficult to decant also then. They were having tracheomalacia and all those things. Just to add to surface.
I guess this ends the panelist question, sir. Now I open the discussion to the audience, and if the audience have any doubts or questions, you could please open up and talk. If not,
Guys, if anyone has any questions, you can open up a mic and talk, or you can just put up in the chat box so the fellow panelists can answer your questions or any doubts you would like to ask. Please feel free to ask.
Thank you, Yashwant, for sharing the global guidelines for diagnosis management of mucormycosis in the chat. That's the article Sir was talking about, the Lancet. So you can download and go through it and have it with you so that you know what is being done in the management of mucormycosis.
Sure, sir. Not a problem at all.
Any questions from any of the audience?
there are no questions. Are there any questions?
Looks like we're not having any questions from the audience as such. So thank you, Sruti, for moderating the panelists. And thank you so much, sir, for coming forward for this session. First of all, from your busy schedule, you actually accepted to come forward for this. So thank you, Dr. Vivek and Dr. Prasanna Kumar, sir. And obviously, unfortunately, Dr. Soma has to leave a bit early because he had some emergency to attend. So thank you so much, sir. And now, moving forward, I would like to invite Mr. Pavan Sarunan. He's the founder of Professional Helpz, one of the coordinators of this event. So it was actually a collaborative event with New World Protocol and Professional Helpz. So he would like to give a briefing on Yukti event, intercollege event, and also about a fundraising event. So Pavan, you can take over.
Yeah. Thank you, Yashwant, for giving me a good intro. Guys, we are actually helping to fundraise for Dr. Abhinand, who's 33-year-old lecturer. Like he almost lost his motor skills. So kindly check it out and try to donate as much as possible, and then share with your friends. Yeah. Now it's about Yukti. I would like to call Abhinaya to explain about what is Yukti event.
Thank you. Thank you for giving us the opportunity to talk about our event. So just please bear with me for 2 minutes quickly. So I'm here to talk about Yukti, which is a national medical summit conducted by the students of Sri Balaji Medical College and Hospital. And we are stepping into the 3rd year of conducting this national medical summit. And this year we have a mixture of hands-on workshops, webinars, and competitions for you all. And the webinar topics include scope of foreign medicine, next preparation, and workshops are conducted by 14 different departments, all of which are hands-on, and it's going to be of great value to the students attending. Like, for example, we have in OBG, episiotomy, shoulder dystocia, and copper T insertion, pap smear, and in ACLS, in emergency medicine, interesting workshops. And we also have competitions like paper presentation, poster presentation, policy reforms, quiz, debate, medical MUN, and a lot more. And we also have a talent hunt on the last day, cultural events like dance, music, stand-up, and a lot more. And we believe that Yukti, provides a platform for all the students to explore the subject beyond borders and unleash all their hidden talents.
and we work so very hard in ensuring to give you all the best experience possible when you attend Yukti. So, and it's happening from 19th to 23rd of October this month. And I have, I think in the chat box, I've linked in the bio. So please go check it out. And yeah, we would really like to see you all.
Thank you, Abhina. Guys, kindly check the chat box to get the link. Now over to the Ashwan.
Yes, thank you, Pawan and Abhinaya. And so, guys, we have come to end of this session. So, thank you all for joining, and hope it was very useful for you guys. And hope you guys learned something about mucormycosis and what all challenges were faced during the pandemic, and how our specialists in the field of ENT and head and neck surgery tackled it. So, once again, I would like to thank the moderator, Shruti Rajagopalan, and Pavan Saravanan, founder of Professional Helpz, who has been working 1 year, last since 1 year. They are a group of medical students all over India, and they formed this group, and they're doing a lot of, they conduct a lot of webinars, a lot of events and fun activities. You can check them out in Instagram, and they're doing a wonderful job. So we collaborated, and thank you so much, Pavan, for coming forward for this. And also, we'd like to thank the team behind this, team Professional Helpz, and as well as New World Protocol, Pavan, myself, Shruti, and also Sriram and Karthik Ashok, and all others, volunteers, everyone who made this event such a success. And of course, our panelists, Dr. Vivek, Dr. Major Prasanna Kumar sir, and Dr. Somu, who accepted the invite and who came forward to make this session a success. So thank you so much, sir. Would you like to say anything, sir? Anything you would like to share with us?
Thank you, guys. It was a really good experience for me, and I would appreciate all of you for making such a great effort and taking out time to learn to become a better professional. God bless you all. Thank you.
Yeah, thank you, Yashwant, for your arrangement, and especially all of you guys for the arrangement. It's really good. Thanks for getting us in. Hope you guys had some knowledge about, at least a little bit of knowledge about mucormycosis and how to go about it, or at least whom to ask for help. So, hope you had a good session today. Good day to all, and have a good evening. Take care. Bye bye.
Thank you so much, sir. Thank you so much.
Thank you so much.
And everyone, we have shared the feedback form, and once you guys fill up the feedback form, you'll be receiving your certificate soon. The certificate is sponsored by Rotary Club of Tiruvallur, so it will really add a good value to your CV. So thank you all so much for joining us, and hope this session was useful to you people. And yep, thank you so much.
Yeah, guys, kindly fill the feedback form. We'll be like waiting 5 more minutes. If you're not able to reach the form, kindly tell us. We can reshare it, and then you'll receive the certificate in 15 days. So yeah, thank you all.
Thank you so much, Pawan, and thank you all once again. And thank you, sir. Thank you so much for joining in.